Thanks, Dr. Bucell. I really appreciate the invitation to join you and our colleagues for this symposium. I'm going to be talking about gene therapy for inherited anemias. Why gene therapy and why now? Well, I think it's safe to say that medical research has advanced over many decades and that we've now identified many diseases that are caused by errors or mutations in single genes. It was also important for us to make progress in discovery of the tools that would be needed to replace what is defective or missing, and that's taken time to evolve. It's also been terribly useful to have animal models for human diseases and to be able to demonstrate that correction or replacement of that single gene would alter the phenotype and potentially eliminate many of the features of these inherited conditions. Most importantly, though, the success required finding safe ways to deliver healthy genes to long-living cells and to achieve levels of the missing proteins or enzymes at high enough quantities for a sustained period of time to make a clinical difference. There are a number of hematologic conditions for which gene therapy has now reached critical stages. Hemophilia A and hemophilia B are now being approached with an in vivo gene therapy addition approach. Immunodeficiencies such as SCIDS, X-linked CGD, and Wiskott-Aldrich are also in clinical trials. But I'm going to be focusing on thalassemia and sickle cell, the major hemoglobinopathies. I'm also going to touch on pyruvate kinase deficiency, as this is an inherited blood disorder for which gene therapy is in development. What is gene therapy? I think it's very important for us to understand this important concept. Gene therapy encompasses any experimental technique that uses genes to treat or prevent disease. Another common feature of gene therapy is typically the patient is used as their own donor. And so in the case of the conditions that I will be talking about, it will be the patient's hematopoietic stem cells. In many instances, it involves an engineered viral vector that's used to insert a normal copy of a gene that is defective or to modify its function. Hopefully in a year or two, this slide will change out because certainly there is rapid development being made using non-viral approaches. There are a number of ways to think about gene therapy. I think in its simplest terms, many people want to think about gene replacement, where if a gene is a cassette, that you pop the cassette out and put a new one in. I think it's safe to say that there are no conditions for which that is possible today. Gene addition, however, will introduce copies of a normal gene, leaving the defective gene intact, and that's important when in my presentation today. It is also possible just to modify the expression of other genes that play roles in the disease phenotype or pathogenesis. And then finally, genome editing or gene editing is also a form of gene therapy, and it directly replaces specific sequences. Sickle cell disease and thalassemia are common blood disorders that are caused by mutations in a single gene called HBB or beta globin. These are inherited conditions that are associated with anemia, but many other complications. In the United States and in other countries, there is universal newborn screening to identify sickle cell disease and to a lesser degree thalassemia. Without treatment, these conditions cause serious disabilities and early death. And so in sickle cell disease, interventions include penicillin, pain medication, hydroxyurea, and now some new disease-modifying therapies. In thalassemia, monthly transfusions and iron chelation are absolutely essential for the management of this condition. And so when we think about gene therapy for these conditions, gene addition will be adding a normal beta globin gene. And so in sickle cell disease, because the native gene is still intact, the goal is to convert the patient from sickle cell disease to sickle cell trait. In thalassemia, where they make little or no beta globin, the hope is to reduce transfusion dependence and ultimately eliminate the need for transfusions at all. Another approach that's currently being used in gene therapy trials is to increase fetal globin. This can be done by adding the capability to make gamma globin, which is part of fetal hemoglobin, making the beta globin gene, which is part of normal hemoglobin A, more gamma-like. It's also possible to alter the expression of genes that regulate fetal hemoglobin. And I'm going to actually talk to you a little bit more about that because there's some really new and exciting findings with this last approach. These are a number of the vectors that are being used in clinical trials for sickle cell disease and thalassemia. At the current time, all of these strategies are employing a lentiviral vector. This has become the vector of choice for many gene therapy studies, even beyond hematology. It is known to be a fairly stable platform, one that is less associated with insertional oncogenesis and transformation in malignancies. And it has the ability to integrate into relatively slow or non-dividing cells, and hematopoietic stem cells fit the bill. In each one of these in red, you'll see that there's a cassette that includes the therapeutic gene, in many cases beta globin, sometimes beta globin with some mutations that have intentionally been engineered, but then also gamma globin. And in all cases, the beta globin, the beta locus control region, which is a natural regulatory sequence within our blood cells, is used in this gene, in this vector construct. I mentioned that there are mutations that can be made to make cells more gamma-like, and one example of this is a mutation that's called T87Q. Now, T87Q is not a mutation, but is a naturally occurring variant that's in hemoglobin F, or gamma globin. But it's known to inhibit the lateral contacts of tetramers, and so may have some benefit in inhibiting sickling. The same is true for AS3, another naturally occurring mutation which inhibits polymerization, increases affinity to alpha globin. I'm going to talk a little about LentiGlobin BB305, as there's quite a bit of clinical data out now on how this vector responds in patients. This is a lentiviral vector that uses the human beta globin gene that has a hemoglobin A beta the T87Q mutation engineered in and is under the control of the beta locus control region. Some very important features are that LentiGlobin, just like all of the other lentiviral vectors currently in use, is replication defective. It's self-inactivating, but in this case specifically, it produces beta A T87Q under the control of erythroid-specific regulatory elements. This amino acid substitution for this particular vector is useful in that not only does it have the ability to inhibit the polymerization, in particular sickle hemoglobin, but it also allows for monitoring of the transgene expression in the patient cells using high-performance liquid chromatography, such that I can distinguish between beta A, which is hemoglobin from a transfused unit of blood cells, from beta S, which is someone with sickle cell disease, from other variants and other types of globin using a simple blood test. This is a general overview of gene therapy. By and large today, hematopoietic stem cells are no longer collected using bone marrow, but instead are done by apheresis with mobilization using either plerixafor alone in the case of sickle cell, or GCSF and plerixafor for other conditions. And then using an automated exchange method, the stem cells are collected. These cells are then sent to a central laboratory where the CD34, which are our hematopoietic stem cells that are capable of self-renewal, are then isolated. They're transduced with the viral vector. They are monitored for certain safety parameters and then frozen. The patients during this time period are home and going about their daily lives, but once their product is available, they are admitted to the hospital and they undergo myeloablative chemotherapy with busulfan for conditioning to not only make space in the marrow for these new cells, but also to minimize the number of remaining unmodified cells in the person's bone marrow. After the drug product is infused, the patient remains hospitalized for their safety. Then they're discharged when they show evidence of engraftment. At that point, we hope to see vector-derived erythropoiesis, and in this case, expression of hemoglobin A T87Q. In most of the clinical trials, the patients are followed for 2 years, but at the recommendation of the FDA, there is a long-term follow-up that's offered to follow them out for safety purposes for a maximum of 15 years. This was shown in a proof of principle publication from the group in Paris under Dr. Cavazana's direction. This was a young adolescent sickle cell patient who was on chronic transfusions for a stroke and therefore had predominantly hemoglobin A from the blood bank. After he underwent gene therapy, you can see the drop-off of the hemoglobin A as his transfusions were stopped, and the emergence of hemoglobin A T87Q, as well as the return of his native hemoglobin S, but now in perfect balance with nearly 50-50 of his new therapeutic globin and his hemoglobin S, and really most assuringly, his total hemoglobin is now near normal. This was moved into large-scale clinical trials, but a number of challenges were realized. First and foremost, this was when we were using bone marrow as a primary source of hematopoietic stem cells. And what we learned in sickle cell disease is that the marrow is hypoxic and inflamed, and as a result leads to low yields of hematopoietic stem cells. At the time, the transduction efficiency was fairly low, and inadequate myeloablation was noted in the first patients, and as a consequence, suboptimal engraftment of transduced cells was seen in the first group of patients. A number of changes have taken place. Transfusions are now offered to all patients prior to harvest to quiet the marrow and to hopefully have healthier stem cells. Plerixafor alone appears to be safe and effective in sickle cell disease. And then the cells are transduced in a slightly different manner and then when the cells are returned to the patient, it's after having received optimized busulfan with the hope of successful engraftment. And in this case, this is group C from the HGB 206 trial. Many of these individuals over an extended period of time now are making substantial amounts of the therapeutic hemoglobin A T87Q with much higher total hemoglobins in the range of 11 and above. And so certainly a very reassuring early result for sickle cell disease. When we look at the fraction of hemoglobin S, their native hemoglobin, compared to the hemoglobin A T87Q from the vector, again, they're nearly in balance, which is reassuring and would be the phenotype for someone with sickle cell trait. Now, there are some aspects of this that are very important to point out, and that is, where is the vector being expressed? When we think about a normal individual, all of their cells contain all hemoglobin A. In someone with sickle cell disease, all of their cells express hemoglobin S, or the beta globin is only an S mutation, and so all of their adult hemoglobin is beta S. When someone is transfused, it becomes an admixture. So there are some cells that are 100% S, some cells that are 100% A, yet it is quite beneficial. What we hope to accomplish is actually to make the individual look more like sickle cell trait. And in that instance, every cell has some expression of not only hemoglobin A, but also hemoglobin S. And so a single cell Western blot assay was developed for these trials. And what you can see over time is, while the individual at the beginning may have had some hemoglobin S, some hemoglobin A reflecting transfusions, over time, and as their transfusion volumes were decreased, the patients have primarily an admixture. So over 70% of their red cells actually make a mixture of T87Q and their native gene, which again is consistent with pancellularity and begins to look more like a patient, say, who has sickle HPFH, which we know is a very benign condition. This is the most important part of the 206 data that was presented recently at the European Hematology Association. And this compares the time period in the 2 years prior to gene therapy and marking out all of the times that these individual patients had vaso-occlusive pain episodes or acute chest syndrome, and then now comparing them to the gold or yellow side, which is all of the time post-infusion. And what I think is striking is there is a 99% reduction in the annualized rate of vaso-occlusive episodes. And so while many of the previous slides that I showed are things that are particularly exciting to someone like me as a provider or as a researcher, this is what matters to patients, to be able to undergo gene therapy and to see the principal manifestation of sickle cell disease, that is vaso-occlusive pain, being relieved by undergoing this procedure. Another very exciting approach has been the development of a LentiGlobin vector that targets BCL11A. Now, BCL11A is an example of a gene that's important for modifying the expression of other genes that are important in sickle cell disease, and I would say, dare say, in erythropoiesis. BCL11A is actually the approach that was taken for this particular work uses a short hairpin RNA interference approach where expression of BCL11A under the expression of native erythroid-specific elements should lead to a reduction in the expression of BCL11A. Now, BCL11A is what turns on when we're about 6 months of age that gradually leads to the reduction of fetal hemoglobin and allows for the expression of beta globin, which is normally hemoglobin A. What we want to do, and what's being done in this particular program, if successful, is that by suppressing BCL11A, it will de-repress or allow the reemergence of expression of gamma globin, which is a key building block of hemoglobin F. And so then allowing the patient to have their natural mechanism for making fetal hemoglobin restored. And this is just an early example from the group at Boston Children's that is spearheading this effort, showing that in the prior to gene therapy, the patient had a number of complications and had sickle cells easily visible on a peripheral blood smear. But following gene therapy, the patient has had no neurologic events and no pain, and their hemoglobin is now nearly normal, and they've required no additional transfusions. What's also noteworthy is that this is an individual who had very little hemoglobin F. He had some when he was being given hydroxyurea, but that following gene therapy, you can see that over time, you've seen not only an improvement in the amount of fetal hemoglobin, but also the total hemoglobin, and most importantly, that it has been pancellular. Now, there are risks for gene therapy, as there are with others, and I would be remiss if we did not include those. Most of the risks that have been described thus far in all programs that involve myeloablative chemotherapy have attributed the majority, and in fact nearly all, of the complications and risk to the conditioning itself, and these are known. Busulfan is likely to cause mucositis, hair loss, but is also associated with increased risk of veno-occlusive disease and also lung fibrosis. Gene therapy, just like other forms of transplant, there's a risk of marrow failure. And as a consequence, every patient has an unmodified backup aliquot stored at the clinical site at the time that the stem cells are collected. Clonal dominance or insertional oncogenesis could lead to cancer risk, and those are also concerns. This has occurred in recent clinical trials, clinical programs for using gene therapy. The attribution after careful laboratory analysis was that these events occurred also due to the use of busulfan. Infertility and sterility are also known risks associated with busulfan. Genome editing is another form of gene therapy that involves the collection of stem cells, performing an editing procedure, and then reinfusing the stem cells. In this case, these require a platform to modify the stem cells by genome editing. And there are two that currently are in clinical trials. One is using a platform called zinc finger nuclease to achieve the modification. Another is using CRISPR to disrupt, in both of these cases, BCL11A, with the hope that you will ultimately achieve a mixture of production of hemoglobin F and hemoglobin S in these modified stem cells. CRISPR-Cas9 is the platform that has received the most attention, and it involves the use of a single guide RNA that's specific for BCL11A, a specific element in the promoter region of BCL11A, and then also a Cas9 endonuclease, which creates a double-stranded DNA. Then the guide RNA is used to actually target and to replace the area of interest in the genome. And then our bodies naturally repair this DNA break, either by homologous directed recombination, or in the case of the current clinical programs, through non-homologous end-joining. This is actually some of the early work that was presented at EHA just a few months ago. This is looking at an individual with sickle cell disease and then also one with thalassemia. So on the left is thalassemia, and you can see this individual has primarily hemoglobin hemoglobin A, I should say, from the blood bank. But that in the time following the transplant, you can see that their transfusion stopped, and that they then reverted back to making predominantly hemoglobin F with a near normal, or in this case, a normal hemoglobin. In the case of the patient with sickle cell disease, they had predominantly hemoglobin S, and then they were transfused up. And then the transfusions were stopped as the patient stabilized. And what you can see is that in the blue bars is the expression of hemoglobin F that is the result of the derepression of gamma globin that becomes almost in perfect balance with their hemoglobin S. And so, but again, what's most important about this is demonstrating pancellularity. And that is what we show here, that the individual with sickle cell disease over time, that the expression of the fetal hemoglobin now de-repressed because of the silencing of BCL11A is pancellular. And so this person has the phenotype of someone with sickle cell trait. But most importantly, the number of vaso-occlusive episodes and the need for transfusions in the 2 years leading up to transfusions continued during the screening process. But following the infusion, of their modified stem cells, that their vaso-occlusive pain episodes were all but eliminated, and they received no transfusions beyond the period of hospitalization following their transplant. Base editing is a new approach for gene therapy that it's worth definitely keeping an eye on. And so while we often use scissors to depict many of the traditional gene editing approaches, whether it's CRISPR, zinc finger nucleases, or some of the other platforms, gene editing, it's easy to think of gene editing being more like a pencil eraser, where there's a direct conversion using a nuclease from one base pair to another. Finally, I want to touch on pyruvate kinase. This is the most common congenital cause of non-spherocytic hemolytic anemia caused by mutations in the PKLR gene. Now, it's not a single mutation, so targeting that single point mutation would be really challenging. But pyruvate kinase is important for conversion of phosphoenol pyruvate to pyruvate in the glycolytic pathway. So very close to the bottom, you'll see it circled. Clinically, pyruvate kinase is associated with neonatal jaundice in its most severe forms, transfusion dependence. Many people with pyruvate kinase require splenectomy. And there was some recent, very exciting early clinical trial data using a disease-modifying therapy, mitapivat. Gene therapy for pyruvate kinase deficiency is using a lentiviral vector that encodes a PKLR cDNA that expresses the red cell-specific isoform. There are also other isoforms of PKLR, in particular, one that's expressed in the liver, under the control of a eukaryotic promoter. There are preclinical trials that have been completed in a PKD mouse model, which demonstrated correction of the glycolytic pathway of the red cells from the corrected hematopoietic stem cells in these myeloablated PKD mice. So as a proof of principle, this has formed the basis for a phase 1 clinical trial that is currently enrolling, but for which there is currently not clinical data. But there are some remaining questions. Will this single infusion be durable? Certainly we hope so. This is quite an undertaking for patients, particularly in the setting of inherited anemias where myeloablative chemotherapy is used and under most circumstances would not be repeated. Are there additional modifications to further reduce risk? I mentioned that infertility, for instance, is a known complication of busulfan and is often one that causes quite a bit of discussion and the need for quite a bit of deep thought by patients and their families before undertaking these procedures. Will results be better in younger patients? By and large, we hope the answer is yes. How would the results using these different vectors differ or align? This is an exciting time in this field given the number of different approaches that are currently reaching the clinical trial stage. Will genome editing achieve similar or superior results? And then finally, a question for us all. What constitutes cure? So I'd like to thank you for inviting me to participate in this symposium.